Welcome to Parkinson TV. My name is Ray Dorsey. I'm a neurologist at the University of Rochester and delighted to be hosting today's episode on advanced therapies for Parkinson's disease. The goal of Parkinson TV is to provide educational content to patients and their families with Parkinson's disease, whoever they are, wherever they live, and whenever they need it. Today's episode is on advanced therapies for Parkinson's disease, including deep brain stimulation and levodopa intestinal gel. To discuss who benefits, what the risks are, and what to expect from these therapies, we have two of the world's experts to discuss these therapies. The first is to my left, Dr. Bertram Donnie from Mount Sinai. There he's an assistant professor of neurology and associate director of the Deep Brain Stimulation program. Next to him is the world-famous Dr. Bas Bloem, who is a professor at Radboud University in the Netherlands and the founder of ParkinsonNet, an integrated care delivery program for people with Parkinson's disease that has made great successes in the Netherlands and is now coming to the United States. Ritesh, can you tell us a little bit about what kinds of advanced therapies there are for Parkinson's disease?
Well, there are really two main advanced therapies that we consider for Parkinson's patients. One is deep brain stimulation, and the second is the levodopa intestinal gel. Many may also consider the apomorphine subcutaneous injections as another advanced therapeutic for the treatment of Parkinson's patients.
And what are the benefits of each of these?
So with deep brain stimulation, it's been around since the late 80s. And what it really consists of is implanting small electrodes into specific regions of the brain and connecting those electrodes to battery-powered pulse generators that sort of sits under the clavicle of a patient. It allows a neurologist or to deliver current impulses into those specific regions of the brain to ameliorate a number of symptoms such as tremor, bradykinesia, rigidity, oral levodopa complications such as motor fluctuations and dyskinesia. The intestinal gel is a port. It's a port that's sort of placed into the proximal jejunum of a patient, and
the jejunum is
it's the upper part of the small intestine, and it sort of bypasses the stomach, especially since gastric emptying issues is common in Parkinson's patients. And the mechanism there is to really deliver continuous level of levodopa in order to treat motor fluctuations as well as dyskinesia in patients who are afflicted with those sort of symptoms.
Let's talk a little bit about who the right candidates are for deep brain stimulation and levodopa intestinal gel. First, for deep brain stimulation.
So, for deep brain stimulation, there's really, the way I think about it, there's three sort of candidate patients. Patients who are afflicted with refractory tremor that does not really respond robustly to high doses of levodopa, oral levodopa. Patients who have severe motor fluctuations where the oral levodopa is just not lasting long enough, and they're sort of in a seesaw pattern throughout the entire day between their off state and their on state, where they feel really good and where they're just very symptomatic with tremendous amount of symptom burden. And then those patients who also have severe dyskinesias, those sort of involuntary movements that are related to high doses of taking levodopa. So a patient doesn't need to have all three of those. Any one of those symptoms that is present that's starting to affect their quality of life, those are the sort of patients that we start to think about deep brain stimulation for.
And do we have an example of a video that you can show us?
Yes, we do. I think this patient here that you're looking at is a patient of mine. She's had tremor-dominant Parkinson's, really affecting her arms, her legs, and has had it for a number of years, and taking higher and higher doses of levodopa with really suboptimal benefit. Her quality of life has been declining over the years because she's not able to engage in the sort of social activities she wants to do because of the tremors, as well as starting to have problems with daily activities of daily living. We implanted her with bilateral deep brain stimulators. As you could see here, her tremors have virtually disappeared. Her bradykinesia, or the slowness, as well as her rigidity, has also markedly improved. And these results are achieved within weeks of implanting the device.
Fantastic. Bas, can you tell us a little bit about who the right patients are for levodopa intestinal gel?
Yeah, so basically the same people who have an insufficient response to the oral medication can be a candidate for any of the advanced treatments. One of the key differences is perhaps the patient that we just saw in the video, the tremor, the medication-resistant tremor patients. The intestinal levodopa gel achieves the same effect as the oral medication, but does it in a more consistent way. So people who are refractory to oral medication will not improve to the levodopa intestinal gel. The interesting thing is the two therapies that we just talked about have never been compared back to back. So basically patients who become difficult to manage with oral medication alone are potentially a candidate for either one of the two treatments. The patient preference is a key factor, but sometimes there are good reasons to refrain from the operation in the brain. And those patients are good candidates for the levodopa intestinal gel. For example, if there are severe mental problems or other reasons why the surgery is maybe too risky for those patients.
Now, both of these treatments are established therapies. Both have been cleared by the Food and Drug Administration in the United States. Levodopa intestinal gel has been around for about a decade in Europe. Can you tell us a little bit about the experience in Europe with levodopa intestinal gel?
It's been a very positive experience. I think one key thing that it's maybe good to start here is it's not a cure for Parkinson's disease. That's true for the deep brain stimulation. It's true for the levodopa gel. They're both very good treatments. They're better than fiddling around with the oral medication once it becomes a very complex stage. So what people can expect is the best moments that they experience on oral medication, but those good episodes become briefer and briefer. What people can reasonably expect is more of those good periods on either one of those two treatments. The experience with levodopa intestinal gel has been very positive in Europe in the sense that people have a better on time during the day. In the initial period, there were some complications with the tube that's going straight into the intestine. Sometimes it became infected or irritated. With newer devices, those problems are less commonly seen now. And I think people can really expect a bit of hope of a better quality of life with this type of treatment.
After the break, we'll talk a little bit about the safety risk and the downsides of these surgical treatments. But as a patient, how should a patient prepare for having either deep brain stimulation or levodopa intestinal gel?
Yeah, that's a very good question. So the first thing, and I want to emphasize it again, it's not a cure or panacea for Parkinson's disease. So sometimes people are almost disappointed because these are magical treatments. You know, it's a surgical procedure in the brain, it's a tube in your intestine, and they think they may be cured from the disease. It's not a cure. It offers better quality of life, more on time during the day, but it's not a cure. So that's one thing in the preparation. The second thing is, if it all goes well, sometimes the improvement is quite dramatic. Not for all patients, but it can be dramatic. So the other thing that I always prepare my patients and the families for is that sometimes the relationship in the family changes. Patients who are candidates for the therapy are usually in a more advanced stage of Parkinson's, are more dependent. Suddenly, after the treatment, they are much more independent. And the relationship between the spouse and the patient then changes again. Sometimes the spouse is more used to taking care of the patient, and now suddenly the patient is more independent. So they also need to prepare for the change in their life, and that's often forgotten.
Thank you very much for sharing your experience and expertise. Each episode of Parkinson TV has a video blog or vlog as part of it. Let's take a look at this week's vlog. Welcome back to this episode on advanced therapies for Parkinson's disease. We're speaking with Dr. Bertram Donnie and Dr. Bas Bloem about advanced surgical treatments for Parkinson's disease, including deep brain stimulation and levodopa intestinal gel. In the first half of the discussion, we talked a little bit about the benefits of these surgical treatments. I'd now like to turn to the limitations. Ritesh, what are the risks associated with deep brain stimulation?
Well, with any surgical procedures, there's surgical risk. And specifically with deep brain stimulation, there's really two risks that patients need to keep in mind. One is the risk of an infection to the hardware, either to the pulse generator that sort of sits in their chest or to the electrodes that are implanted. That risk is somewhere around 3 to 5% globally if we look at the composite of experiences across various DBS centers. And the other risk is the risk of a stroke, a small hemorrhage that happens at the time that the neurosurgeon implants that electrode. That risk too is around 5% globally. But you sort of minimize those risks based on the approach that center takes in a multidisciplinary fashion and with the experience of a neurosurgeon. So we always recommend that patients who are considering DBS that they should go to centers that have the experience, whose complication rates are low, who are very experienced when it comes to targeting and putting that electrode where it needs to be.
How would patients find out which centers have experience?
Well, there's many resources out there. Usually patients go to their physicians first. The neurologist is their first line of information. And then the internet. Dr. Google, as we say, would be the best way for many patients to learn about various DBS centers. And also we find that, from our experience is that patient referrals, the patients in support groups, at Unity walks, at other Parkinson's foundations, they talk, they intermingle, they share experiences, and that sort of also is a way for information about which centers has experience, what the experience was like, because this is a process. Every center implanted a little bit differently. Some implanted staged, meaning that the surgeries are done over a course of several weeks. Others do it on the same day. Everything is implanted. So the subtleties and the nuances of the different approaches needs to be discussed with the patient for them to really feel comfortable with whichever surgeon or whichever team they decide to go with.
So I'm not familiar with all the websites in the United States, but I think it's worth mentioning the Michael J. Fox Foundation, who has useful information about reliable and good centers, and the National Parkinson Foundation, which is an important patient foundation here in the United States, and they also offer reliable information about where you can find good centers.
Yeah.
And patients should feel free to ask their physicians how many times have they done this surgery, and to talk to other patients that have had that, and what their complication rate is.
Exactly, and the surgeon implanting it as well.
If you want your roof fixed, you ask the plumber, have you done it before?
Yeah.
Now somebody's going to operate in your brain.
Right.
You want to know whether the guy has experience.
Right, and I think it's also important that whoever is evaluating these patients understand what their baseline Parkinson's state is. It makes a difference in terms of targeting because there are different targets that the electrode could be implanted, and makes a difference on the post-operative side of things as the way, in the manner in which the stimulation is sort of integrated into their life over the ensuing months. It takes about 3 to 6 months to get a deep brain stimulation patient fully optimized, and the reason for that is that it's life-changing, just like the intestinal gel. It's life-changing, and in my experience, I've found that patients who have carried disease burden for so many years sort of forget what normal feels like.
Exactly.
And so gradually bring in stimulation into their life, or the intestinal gel infusion into their life, modifying medications with deep brain stimulation. The ability to reduce medication can be substantial, upwards of anywhere from 40 to 60%. And that can make a major difference in a person's life, especially if they were having not only motor side effects from the oral dopaminergics, but also cognitive side effects. Yeah. Some of the dopamine agonists, as you know, can cause impulse control behavioral disorders, and getting patients down and off of those medications can certainly make a big difference from a cognitive and psychiatric standpoint as well.
We'll definitely talk about impulse control disorders in another episode of ParkinsonTV.
Right.
Bas, Ritesh told us a little bit about the surgical risk associated with deep brain stimulation. Can you tell us a little bit about the safety risk associated with levodopa intestinal gel?
Yeah, the procedure itself is actually, in the doctor's perspective, a relatively minor procedure, so patients don't need to worry too much. The patient perspective is always different, of course. I think patients need to prepare for the fact that their body has changed. There is now suddenly a hose sticking out of your body, so you need to be well informed. What we're actually doing in the Netherlands is not letting the doctor just making the exclusive decision, but inform patients very well about the procedure, the pros and cons, and also what it looks like after the surgery, so that patients can really participate in making the decision whether to go for the gel option or for the surgery option. So for the gel, the surgical procedure itself is relatively minor. What patients need to prepare for is, it's not an immediate effect, so you need to fiddle with the dose. So I think the time to reach a full efficacy is a little bit longer than compared to maybe the surgery. And one concern that we still don't fully understand, which is fortunately a relatively rare complication, is a vitamin deficiency. Maybe because we're fiddling with a hose sitting in your intestine where the vitamins are being absorbed into the body, for some mysterious reason, some people develop a vitamin deficiency, so that needs to be tracked over time, because it can cause a so-called polyneuropathy, numbness or tingling in the legs in particular.
And they can get these vitamin levels checked and get vitamin supplementation.
Exactly, and then it can be hopefully solved or at least detected in an early phase. For some patients, it's necessary to actually remove the hose when it's really bad, but fortunately, it's a rare complication.
For each episode of Parkinson TV, we get questions from our viewers. One question comes, I have a lot of mood swings. Could any type of advanced therapy help me?
Well, when it comes to deep brain stimulation, hasn't been shown to really directly impact mood or cognition. But that being said, if the mood swings are related to fluctuations, because some patients could have what we call non-motor fluctuations, that stands to improve with advanced therapy.
Can you tell us a little bit what a non-motor fluctuation is?
So non-motor fluctuations are sort of symptoms in which patients may manifest anxiety, feeling of panic, feeling of sweating, clammy hands, restlessness. It tends to happen around the same time that the medication levels in the bloodstream is starting to wane or to decrease. And it accompanies the motor symptoms, so their Parkinson's symptoms return. So I think, we haven't seen any data to suggest that DBS directly impacts non-motor symptoms. Yeah. I think it may be, and experience and future studies will bear this out, whether continuous levodopa infusion can help with something like that. Yeah.
So I think in my experience, so the best antidepressant in Parkinson's disease, in my experience, is a dopaminergic medication. Yeah. One of the problems we sometimes see with DBS, with a surgical procedure in the brain, is that it's very effective for the motor symptoms. So you actually need to reduce the dose of the oral medication. Suddenly, you now miss out on the dopamine in the other dopaminergic circuits in the brain, where you need the dopamine to improve mood. So sometimes actually mood swings get worse with the DBS because it's excellent for the motor treatment. Patients come back to the clinic, their symptoms are perfect, but they're not happy because they're missing out on the oral dopamine they need for mood. So people with mood swings, I would probably prefer the levodopa gel over the deep brain stimulation.
Yeah. And I think, Buzz, you bring up a very good point in terms of, the mood swings that patients can develop in the post-operative phase once stimulation has started. And that's why, if done correctly over the course of 3 to 6 months, and that's usually the paradigm that we operate on, is that small adjustments, reductions that are appropriate, that are well tolerated, because we know that if medications are reduced too quickly, we put these patients at risk for worsening their underlying mood swings or triggering it.
So we know both that deep brain stimulation and levodopa intestinal gel decrease off time. One question our viewers have asked is, how does deep brain stimulation affect speech?
Yeah, there's a lot written about its effects on speech. And what I could say is this, is that the data is controversial. It's equivocal for the most part. The studies that have shown that it impairs speech or negatively impacts speech usually don't take into consideration the underlying baseline of the patient. What was their speech like prior to the operation? It doesn't usually take into account where the electrode is, anatomically in the brain. We don't control for those things. We don't control a lot for medications. So it's a little bit, it's not clear. What I could say is that a well-placed lead should not cause speech issues. A lead that is malpositioned or a little bit off, where then you're dealing with spread of the stimulation into regions that you really don't want it to, can cause symptoms like slurring of speech or a reduction in the vocal intonation of speech. In our experience, and there is some data to support this, is that patients who have an underlying speech issue with Parkinson's, specifically a reduction in their vocal intonation, are a little bit more at risk for having that symptom get worse with a specific target, which is the subthalamic nucleus has been more associated with that. That's why, it comes back to my earlier point, where understanding a patient's Parkinson's baseline, what their symptomatology is, what is their response to medication, what is their, how is this affecting their quality of life, and then seeing whether deep brain stimulation can help those specific symptoms that they're complaining of. And I think that makes a difference, and it minimizes the risk of any sort of deterioration in speech.
Can I just, so it's interesting, the Dutch and the Americans think exactly the same, so I totally agree with what you said. Sometimes I see patients for whom their voice is critical, like a professor who still wants to deliver speeches. So while the jury's out there, and while a perfect surgeon and a perfect position of the lead should not be a concern for speech, there is this small risk, and there is a concern. So if speech is critical for the patients, I want them to reconsider whether DBS is the optimal treatment for them, because we don't know for sure, and because speech is so vital for your communication. And for those folks where speech is their key element in their life, be a little bit concerned.
Another question on levodopa intestinal gel. So levodopa intestinal gel has basically a feeding tube coming out of the stomach that's then connected to a pump that's pumping in levodopa, and they carry around this pump wherever they go. One of our viewers asked, can I still travel when I use levodopa intestinal gel? Yeah,
people can still travel. The gel is intended to stay good for a longer period of time. I know, for example, I went to the WPC, the World Parkinson Congress in Portland. There were patients from Holland who brought their levodopa gel in a suitcase with them. I think it needs to be chilled for a period of time, but people can certainly travel. We can speak for hours about how people with Parkinson's can and should travel. The intention, of course, for Parkinson's is lead a meaningful life. So traveling, yes. And of course, you need to discuss with your physician how your medication schedule should be maybe adjusted when you travel with or against time. But traveling is definitely possible with the levodopa gel.
So most activities are possible with deep brain stimulation and levodopa intestinal gel. Are there any activities that patients can't do if they have levodopa intestinal gel?
I would probably avoid bungee jumping, but I would generally avoid that. I think that the good thing about the levodopa gel is, if all goes well, you'll have better on time and be much more independent and be much more active. I would avoid crazy things like bungee jumping, but otherwise people can lead a meaningful life with the levodopa gel. Any
limitations for people who've had deep brain stimulation?
No, I agree with Buzz. We as long as especially for some of our younger patients who are very active and want to engage in sports, we caution them and really against high impact sports where they could incur trauma to the area around the neck where the lead is coursing. And remember, the lead is all under the skin, and the pulse generator sits in the upper chest. So anything that puts that lead at risk for trauma, such as impact sports, roller coasters, bungee jumping, skydiving, those are the sort of activities that we really caution and really try to deter our patients from engaging in.
I love your final thoughts on advanced therapies for Parkinson's disease, Ritesh.
Yeah, so the world of Parkinson's has evolved and changed over the last 20 to 30 years, and advanced therapies is ushering in a new era for us in which we can really make a difference in patients earlier than later. We used to wait on 15, 20 years before we thought about deep brain stimulation. And these patients would go 2 decades with on rising amounts of medications, side effects from these medications, motor complications related to it, and a diminishing quality of life. Now here we have an opportunity to offer them hope, give them a better quality of life, enable them to engage in activities such as exercising, which will be on future episodes. These are the sort of activities that have disease-modifying agency and can help really make a difference in their progression over time.
And Boss, maybe if you look into the future a little bit, there are new therapies, new surgical therapies, both tied to medications, gene therapy, and focused ultrasound that are in development. Can you tell us a little bit about what advanced therapies of the future might look like for Parkinson's disease and when we can expect to see them?
Yeah, everybody wants the cure. And as much as we hope that the cure will arise, I think that's going to take time. I think the good news for all the people who are watching Parkinson TV is lots of good researchers are working on Parkinson's disease. We're beginning to understand why cells are dying in the brain. I think in our lifetime, for many folks, it is realistic to expect that we have better symptomatic treatments to suppress the symptoms and to lead a better quality of life. And the levodopa gel and the deep brain stimulation is already here. There are other surgical therapies like the ultrasound, which is basically a less invasive way of replicating the effects of what the deep brain stimulation is doing. I think that in our lifetime, we will hopefully see new interventions arising that may be able to slow down the progression of the disease, not stop it entirely. The next step is to hopefully stop it. And the cure, as much as I can hope it will arise, we can't promise that to people yet. But it's good to know that many good people are working on Parkinson's disease. And I think we will see better improvement in quality of life in particular in the next decade.
Dr. Bertram Donnie, Dr. Bas Bloem, thank you very much for your participation in this episode of Advanced Surgical Treatments for Parkinson's Disease. This concludes this episode of Parkinson TV. In order to make Parkinson TV valuable for you, please provide us your feedback on this episode and other episodes or other topics that you'd like us to discuss. We'd be delighted to create those episodes and increasingly allow you to be able to manage your condition, whoever you are, wherever you live, whenever you need it. Thank you very much.